Hey guys, Don here. Welcome to the Million Dollar Minute, where I'm going to go over the things in the practice that help us get to the $1 million mark and beyond. And I want to give a little shout out. I had a really nice conversation yesterday with one of my colleagues. So I'm in Worcester and Westboro, and we have some colleagues in Shrewsbury. And one of the docs there said he listened to the podcast, so that kind of makes me happy. I don't know who listens to this, so if you guys are listening to it, send me an email if you like it, if it's beneficial. Please just let me know, because it's kind of a lonely endeavor here doing this, because I don't get much feedback, but I'll continue to forage on here. I want to share a little experience. Actually, this is about this other doctor and I called him on the phone. So one thing I think is, if I get some patients coming in from another doctor's office, sometimes it might be something they don't know is going on, and I would want the same done for me. So in this practice, I talked to the doc, and they said they're having a little bit of a hard time with front office staff. And what happened is there was the exiting of a more senior doctor that had been there for a number of years, and a lot of the practice was like a routine practice. And I think, and sometimes we get this, I'm sure you get this in your office, where someone comes in and said, hey, yeah, I've been seeing this doctor every 3 months forever, and insurance always covered it. And when you look, they don't have any class findings, there's no neuropathy, there's no, diabetes, nothing else like that. And we have to have that difficult conversation with them. And the way I have this difficult conversation with patients is I say, I don't know how the other doctor billed. You could certainly go back to the other doctor, that's fine, but I'm young, and I don't want to commit any fraud. And when you use the word fraud, they no, I just want to do kind of what's right. And I said, okay, so what I'll do is we send over something to your doctor, and your doctor has to say if you have any class findings, or if you have any conditions that would make routine care covered for you. And this is kind of how I do that. And so our office sends it over, and if there's nothing, then they just pay us, and we do $75. I know other doctors do like $100. I think we probably should move it up if we want to reduce the routine care in our office. But I think we're doing well with our half days. I think it's working well. Another kind of issue, I had another patient that came in kind of as a second opinion, and this was a kind of a difficult situation. I think this happens to some of us as well. So I want to share this. I know I do nail samples. You can see many, many times I'm doing a nail sample on patients, and then they come back in 3 weeks. I review the nail sample results with them. And sometimes, usually happens once or twice a year, a patient is really upset with the pathology bill. And I kind of am too, because the pathologist, they make probably just as much as I did on my office visit, if not more, just for looking at their nail. And so hence one of the reasons of maybe doing in-office pathology if you can. I just know the setup is kind of expensive. But like a patient came from this other doctor's office and said, yeah, they charged me $500 just to look at my nail sample, and there was no fungus. And that kind of seems extreme. So I'm not sure a way around it. I know some doctors, like one of my colleagues here, he doesn't even do nail samples. He just treats people empirically for nail fungus. And I don't know what your thoughts are on that. I may start giving patients the option, so we can do a nail sample, but there might be a bill for that, or we can just kind of do the whole treatment. Because if you think about it, if they just do the whole treatment, and let's say it's $500 or even $300 to examine that nail, they could get my whole kit and everything else like that for that amount if they have a high deductible plan. So I think having these conversations are something that we need to do. And then finally, what happened, the real thing that made the patient come over, and I just like to share this for everyone, is the front office staff, when she asked about the bill and she asked about why the nail sample was done, they just said, oh, that's what the doctor does. So I think sometimes the front office staff can be either the maker or the breaker of the office. So you have to really be careful who's in that front office, who's in that seat. Okay, for today, there were 21 appointments, 20 minutes open, so there was one appointment that was open. Starting out, there was matrix follow-up, and this patient, they were doing fine, and he also wanted a second pair of orthotics. So when patients get our orthotics, they also get a little letter in there that says, hey, if you want a second pair, we would recommend it because it helps with compliance of using them, and so he got a second pair of orthotics. Next patient was a patient that she came in, referred from one of my other colleagues here. She had incurvated nails. So they work really well if it's wider at the base and narrower at the front, meaning it kind of incurvates as it goes forward. And so I trimmed out the edges and I put bilateral Onifix on this patient. I don't do a ton of Onifix, but this was a case where I think it's going to be better. And she had a kind of a narrow nail if I would take out the edges. So we're going to try the OniFix, and she's going to come back as needed. There's another patient. He was a MD PhD student. Came in for a matrix follow-up. He's doing fine. No need for follow-up for him. I'm trying to, as I mentioned before, I'm trying to reduce these matrix follow-ups, but now it's winter, so I have a little bit more open slots. So I kind of do it based on need. It's a little bit slower now, so I'm having some of these patients come back now versus maybe when I get slammed, those are the ones I would be cutting out. Next patient was that EPAT. This is on the Achilles. This is that patient that had a spur resection by another orthopedist, and here for a second opinion. He's number 4 out of 6. He's already feeling much better. Another patient was a 76-year-old female, came in for a routine care, so she's going to come back on our routine day. Another patient came in for Swift number 2. She's a 42-year-old female. She tolerated it well for the Swift, and she also wanted to do something topically, so I gave her imiquimod for that, and she's going to put that under occlusion as well in conjunction with the Swift. So she has 2 more Swift appointments scheduled. Another patient came in for a little girl, cracked nail at the base. And I really think the cause is probably a longer nail and a tighter shoe. So I gave her shoe recommendations, my anatomic shoe recommendations on my shoe buying guide. Another patient came in, her sister came in. So the sisters came in. That was the 12-year-old. No, this is a 17-year-old. She had a little tinea pedis, so we gave her ketoconazole, did a nail sample for possible fungus. And I'll see her back in 3 weeks. And also, she has bilateral bunions, so I'm going to get some baseline x-rays. Actually, not so much bunions. She has more of a dorsal bunion, so a functional hallux limitus. So I tend to see these and recommend orthotics, doing a Cluffy wedge and first ray cutout. And so I kind of discuss that, and so we'll get the x-rays and see if they want to do that at the next visit. Next patient was a 68-year-old patient, came back for a nail sample, was not fungus, and I'm going to see them back in 1 year for a diabetic foot exam, and they like this product that we have. It's called Amerigel Blue, so it's just a foot lotion that it works really well. Another patient came in, 84-year-old female, for an orthotic follow-up. She's feeling much better with the orthotics, and I took the opportunity to do a short little video, so it'll be a YouTube short, kind of letting you know which ones I'm doing videos for, just so you know. I tend to make my content with patients, so I try and sometimes I'll show their face. If I do, I try to get consent. Most of the time, I'm just kind of sharing their story. Another patient was a 51-year-old for EPAT number 2 to the plantar heel. They're doing well, and that was the morning. Afternoon, first patient of the day in the afternoon was a Qutenza number 2. Now, let me tell you my dumb story, my mistake. So with Qutenza, there's 4 little packages, and my staff leaves the packages out. And then, so what I do is there's 3 cut lines. It's kind of like when you're opening up like a check that comes in the mail. You cut on 3 borders, and you open it up. So I did this. So I cut the 3 all at once, and then kind of pull out each of the Qutenza. What I didn't realize is I thought the Qutenza or the capsation was only in the sticker part. But it must be in the package as well. So as I'm cutting this out, then I put gloves on and then I apply it to the patient. But then after I take the gloves off, I'm like I had wiped my eye, and all of a sudden I'm having like capsation in my eye, and I'm like, oh my goodness, what's going to happen? Is my eye going to fall out? But so what I realized, which I probably should have known, is that even when I'm cutting and taking the capsation, these little stickers out of the bag, little paper thing, put gloves on. Okay, so if you're doing Qutenza, do that. Don't do what I did. Next patient, 63-year-old patient, came in for shoe recommendations because she has a bunion, and this is kind of the one that needed nail care as well. Came in from another office. Another patient was this was a 58-year-old female. She came in for a bunion follow-up, got x-rays. So I referred her to one of my colleagues for a lapidus because she has a larger IM angle, and she was concerned about the long surgical time. So I don't know. I think she may have just liked me and wanted me to do the bunionectomy. So I told her I'm scheduling out really far, but she still wanted me to do it. So I'm going to have her added to the schedule. But I don't do lapidus. So I tried to get my other buddy to do it. He would. I guess she didn't want him to do it. So I'm going to do. And I did document. I think she would benefit from that more, but she wants something else. But she's a little bit older. She's not too concerned about having a perfectly reduced bunion. Next patient was a 61-year-old female for a fracture follow-up. So this was, I think my buddy was getting back at me. So I have a couple of colleagues here. They do a lot of the rear foot and midfoot surgeries. And so what I tend to do is I work the patients up and then I send them over to them. And they get all pissed because I tend to get all the higher level office visits and all the non-surgical treatments, like the shock waves and things like that, and then I send them for the surgical repair. So the joke is, so this one had a fracture, so he did the fracture, he got the fracture code, and then sent the follow-up for me. So I think he's just getting back at me. Next patient was my MVP patient. So this MVP is, I always think it's good to look at your schedule and try to find out what's the most valuable patient of the day. This is a 55-year-old female. She's been dealing, she was seen us over 3 years ago, but then she had some heel pain and she went to see someone else, and she went to see 2 other people. And they did the traditional cortisone injection, orthotics, which she left in her other shoes, everything else like that. And then she went to see a NP, a nurse practitioner, over at UMass, which is the big institution. And they got an MRI. I think they tend to get a lot of MRIs, and it showed kind of thickening of the fascia. And she wasn't getting better, and she didn't know what to do. And she did physical therapy. She did dry needling. And I said to her, gosh, I wish you had come and seen me sooner. I did an ultrasound, showed her that one side is a lot thicker than the other side, which is my key for all treatments, is ultrasound, especially with soft tissue things. And then she was kind of totally bought it. So she got x-rays, she got ultrasound, and I explained the whole idea of the thickness of the fascia. And so she got 6 sessions of shockwave. At the second session, we're going to do an amniotic injection, and then she's also going to get a new pair of orthotics. So the first time I did the shockwave and the orthotics, and the second visit I'll do the amnio, and that was the MVP patient. Next patient was a hammer toe follow-up patient. They're doing better. Next patient was a 59-year-old female for a nail sample follow-up, and she got tryptophan. Now this one did not want like the whole kit that goes with it. She was like very explicit. I think she just didn't want to spend money. I know we sometimes have that, but I just even like to tell you that. So not everyone accepts my whole package thing that I talk about, but she's one that did not. Next was an 18-year-old female. This was a girl. I was like, where are your parents at? She looked so young, but she was a high school senior, and she's 18. And then I went over the whole wart treatment process. These are my wart slides, and I'm finding more and more with these slides, patients are opting for the Swift. And so she got Swift number 1 today, but she had to talk to her parents and about that, and she also had a miquimod. So she was a second opinion, seen by a dermatologist for many, many visits. They gave her the topical salicylic to put on. They gave her the imiquimod, and then they referred her over to see us for Swift or for whatever. And then an ulcer patient follow-up. This was a patient that had a ulcer long-standing on the plantar first med head, and then he had a kind of an incident with his, he went from one Arizona brace to a new one because his old one was worn out. But that new one kind of caused an ulcer because it had a kind of a beefed up plantar medial, almost like a varus wedge in the Arizona brace due to his foot type, and that just ulcerated everything because he's very neuropathic. And we've been dealing forever getting that closed. That one's closed. Then he developed one of his fifth toe. That one's not closed. And so I'm almost thinking about, because he has a kind of a chronic Charcot that's stable, getting him into a shoe first and then getting him back into another Arizona brace. I'm just afraid that brace, the newer brace, they just kind of cause a lot of problems on his foot. So I'm going to try to get him into a shoe so we can get out of the boot and get more mobile. And then the last patient of the day was a bilat colat matrixectomy in the office, who will do a 3-week follow-up. And I was also treating him for some plantar fascia, Achilles tendonitis, so I'm going to review that next time. So anyway, hope you guys enjoy this. If you like it, let me know, or let other people know. Please put a review wherever you're listening to this online. Okay, thanks.